Great. I'm Robert Kahn. I'm at Cincinnati Children's, and this was actually a great panel because I feel like I'm presenting integration of what the last two folks talked about as expressed in thinking about the health of kids in Cincinnati. So I'll talk to you about population health data and how we're trying to use it to address social determinants of child health. So I'm going to put up a couple clinical challenges and use them as a way to essentially address what Matthew was just talking about. How do you get a clinician to think about population health and social determinants? So a 12-year-old female with her third asthma admission in 5 months, one to the ICU. So not as sexy as House MD, but in some ways more complicated than the cases he faced. A 23-month-old male with a fall down the stairs that had no gait, and a 20-week premature female infant whose mother had one prenatal care visit and did not return. And from a clinical standpoint, you could look at every one of these and say, oh, how tragic, what a misfortune, what bad disease, what am I supposed to do about that? We threw everything in the books at this 12-year-old with asthma, pulmonary allergy, health educators, but didn't make a difference. And there was an epidemiologist, a very famous AIDS epidemiologist, who once said the epidemiology in public health is about turning what appears to be a tragedy and finding the injustice in it. And so what I'll present to you over the next 8 or 9 minutes is our beginning attempts to think about that. So this 12-year-old, again, had every advantage, and I could have seen her in my exam room and just added one more medicine or just wagged my finger about, are you really taking all your medicine twice a day or 3 times a day? But if you look at her from a different perspective, here's a map of Cincinnati. We've seen a couple hotspot-oriented slides earlier today, but this is all admissions to Cincinnati Children's over the course of 3 years, taking their address when they register. John Bessel in the audience has helped us with some of this work, so a nod to John, and creating a heat map of where the low rates and high rates of asthma admissions are in Cincinnati. And what you see there is in the urban core, around the interstates, the hot red maps are high levels of admission, and the cooler yellow areas. And the question is, if I knew this as I saw her, would I think a little bit differently? And Edward Tufte, if anyone's ever looked at his visualizations, talks about you put up a map and people start to tell a very different story in their head. Where do I live? Where do they live? Where do I travel? What's the story that's driving a whole cluster of high asthma activity as opposed to what is this one child, one family doing wrong in managing their asthma? But this map sort of hides a different level of injustice. And what you see here now is the exact same data, and instead on a map with 5 gradations of color, you see it across the 80-plus neighborhoods of Hamilton County. And depending on where you want to cut it, there's 10, 20, 30-fold variation in these rates of admission. And I love showing this to geneticists who think the answer is in our genes. And I say, oh, isn't it amazing how all those genetically inclined people happen to live in those worst quintile neighborhoods? And they're like, yeah. I said, no. It's really, and even if they did, it's about the environment in those neighborhoods that's triggering those susceptibility genes. And in fact, how can we think differently? Now, if you've heard of income inequality and various coefficients to measure income inequality, if you map child health inequality via the asthma admissions, we have worse health inequality in Hamilton County for kids than we do income inequality in the U.S. Their health inequality Gini coefficient is about that of Brazil's income inequality. So tremendous inequality. Now you could say, okay, for asthma it's bad, what are we going to do differently? But sequentially now, here's neighborhood injury rate, here's the neighborhood preterm birth rate for the county, here's the neighborhood psychiatric admission rate, and again and again and again you see these incredible gradients, and by taking a population health perspective, it shifts you from what do I do for one patient in my room for one condition to what are the root causes and what are the common causes, and are the same neighborhoods showing up again and again, and maybe the answer isn't in my exam room, but trying to figure out what's going on in those neighborhoods. And if I were to show you a plot of any 2 of those conditions, you'd see the roughly linear line that the same conditions show up in roughly the same neighborhoods. So now I'm going to take you a little bit deeper dive in Cincinnati around asthma. So this is now that urban core. A couple years worth of asthma data. Each blue dot is sort of a jiggered enlarged blue spot of where a kid was admitted. And just focus your eyes on one of those blue circles. And I'm going to click it and go back and click it. And so in both slides, there's a cluster in those blue dots. And the question is, what's the difference between the 2 slides? Well, the first one was asthma admissions. The second one is actually legal aid housing conditions cases. So Legal Aid Society takes on cases where landlords are not keeping up their promise for safe and healthy housing, or where there are evictions going on. And through a process of working with a little legal aid and thinking about these social determinants of health, they agreed to work with us to map where their housing cases are, and what you immediately begin to see is this overlap, right? That the bad asthma cases are clustering where there's bad housing. And again, while I can pour more Flovent or inhaled steroids into those housing units, one child by one child, maybe the answer is really in thinking about what the landlord has going on there. And I'll just share one case. We have trained the residents to ask about housing, and especially in the context of asthma. And we had a case, it was hot summer, now 2010, 100 degrees in Cincinnati, and the resident asked what's going on. And the mother said to him, well, I want to put an air conditioning unit in, but I was told by the landlord if I did, I'd be evicted. And this eventually made it to our lawyers, this notice to all residents. If you can't read it, it says, at this time, all residents are not permitted to install any AC units for your apartment. Anyone with an AC unit will be evicted immediately. So the resident referred to legal aid. A week later, there was another case, a different resident. A week later, one of the attendings did, and legal aid said, 3 cases like this, what's going on? And they asked a question that a doctor wouldn't typically ask, which is, who owns the building? What it turned out, it was we hadn't just referred 3 cases, we had referred 16 cases over the past several months, and it wasn't just one building, it was 19 buildings. And it was a single landlord who owned them all, who had gone into foreclosure. All the buildings were plummeting in quality with leaks and so on. It was in foreclosure. Fannie Mae was involved. And legal aid went in and formed tenant associations. Went after Fannie Mae, got literally close to $1 million worth of repairs on the units. And I sent my fellow out at the time to go take a picture that rather than the answer being more medicine, the answer in this case was putting a new roof. So this is a repair on one of the buildings in Avondale that because of the court case and the $1 million in repair, many roofs were replaced, AC, HVAC, and so on. And that the answer then with the population health data took us from a single case to a broader cause across 19 units, 19 buildings, almost 700 units in those buildings. Subsequently, a Choice HUD grant was awarded, and many of those buildings are being renovated now as we speak. And this was a nice article in the Cincinnati Enquirer that the RX for asthma was not more medicine, but was healthier housing. But beyond legal aid, obviously, there's a whole network. We heard earlier about networking for public health systems. And when I think about these social determinants, the question really is, how do we build a network to address the social determinants? When I think of what our families need, whether it's promoting health, we have HCAN, I don't know if Judith is still here, meeting basic needs like legal aid and food banks and Cincinnati Works, helping parents reach their own potential around parenting, and then caring and educating for kids. I see ECS here. And others. But I think the real question would be, as we develop these population health systems, how do we use our data to coalesce around shared goals, create the right incentives, so that just as easily as that resident refers to legal aid, we can refer to Every Child Succeeds, or we can get a community health worker in the home, or we can get a parent who aspires to get back to work to find a job that's opening. We're using our waiting room, so we have over 60,000 visits per year across our 3 clinics alone, and then if you add the health department clinics, it'd be many thousand more. How is it that we can use that waiting room space? Somebody once called them, they're not waiting rooms, they're wasting rooms. But you can imagine if you had this information system figured out to meet families where they're at. So this is one of the many projects we're working on. Getting to the issue of social connections and empathy, it's not enough to create the system, right? You have to create a system that's of value to the families. And this is a couple of projects we're working on are reflected here. It's an effort, given when we mapped our families and we're taking care of half of all the kids in the neighborhood in our backyard, what would it take to get us out of our very big box primary care center? So we have a couple things going on the top 2. This is a prenatal program we're working on with Every Child Succeeds and Cradle Cincinnati and others, where OBs, home visitors, health workers, pediatricians are actually in the neighborhood. They bring their clients and their families that are from the neighborhood, and we meet and we just have dinner together and sort of limit or mitigate the power differential that typically happens when you're in an exam room by just sitting around and breaking bread. On the bottom is a program we're having. We're trying to get our influence leaders in our clinics out in the neighborhood, so several neighborhood groups organized an opportunity for some of our clinicians and nurses and social workers to be in the community. So I think, again, you can build a whole system, but if you're not building mutual respect and empathy, it won't make the difference it needs to make. Just a final nod again in the direction Matthew was, and I talked to Mark probably about 4 years ago around some of these projects, but how would we then take our mapping of asthma ED visits and census tract and figure out crime rate, poverty rate, housing code violation, where are the medically underserved areas, and again, just building off what he said, how would we integrate that in a way so now you have an empathic physician who knows the distribution of health and risks in the community and create it something where in the flow of care of a 12-minute poorly Medicaid reimbursed visit, you can actually have a different kind of encounter with families. Finally, it's all about results. So I'm just going to show this one chart. What this is the rate of asthma admissions for kids on Medicaid in Hamilton County. Drs. Mona Mansour and Kirksmar have led this effort with school-based nurses and many others. But what you see over time by implementing a whole series of these kinds of interventions, a steady drop over the last 3 years that they've been working in asthma admissions for the county. And again, the bottom line is, can we get to results from all these programs? We decreased from 7.2 to 5.4 admits per 10,000 per month. That meant almost 200 kids not admitted in 2014 because of this more public health, population health-oriented work. So I'll finish now and just say what are some of the early lessons, and we're pretty early in this journey of how to use this data to address disparities and determinants. We have to improve clinical outcomes for every child, and also to reduce the disparities. So the key words there are every and the disparities. Every one of the program in which we can report great results. But when you go to the public health data, the results are often not as good as what you would think. And it's what was brought up earlier, it's the people falling through the cracks. So how do you reach every child? And also you can improve the average, but if you're not attendant to the equity issues, you can mask some interventions that just increase disparity rather than limit them. Second, it's a focus on the denominators. Otherwise, as I just said, we get great silos but lousy outcomes. And that includes knowing where patients live, where the key neighborhoods are, and where our programs have the largest overlap with those neighborhoods, and how do we get back in touch with those neighborhoods. It's building an effective network of partnerships to address the social determinants and using data on shared clients and shared geography. So that map I showed of legal aid in our clinic, knowing that the very same families are walking into each of our places. I sit down to a principal and I say, same thing, I know half of your students get their medical forms signed in my office, and I've never sat down to talk to you about the 10% who could really use us working jointly together. Every Child Succeeds, many of our clients are shared with them, and we're trying to work through the confidentiality issues and care management issues. Finally, taking a public health systems approach to health risks, as I mentioned, and developing deeper understanding and empathy along the way. And finally, to a couple comments made earlier, this resonates, hoping that payment reform eventually incentivizes this kind of change. Because right now we're paid for volume, and every time you see those 185 kids not admitted, it's essentially a revenue loss until the payment system changes and we really get reimbursed in an ACO-like system. Thank you very much for your time.